Hi friends, I welcome you all for this session. In this video, we will explore how to assess cortical maturation in fetal brain. By the end of this session, I'm confident you will have a clear understanding of how to evaluate various sulci that appear during fetal brain development. The development of sulci and gyri reflects the ongoing process of neuronal migration, which is the key aspect of cortical development. And that's why their assessment is so important in prenatal neuroimaging. It is important to note that there is often delay between the actual anatomical formation of this sulci and their visualization on the imaging. There are two types of sulci, primary and secondary. Primary sulci are major indentation that first appear in the brain. They serve as the foundational landmarks and indicate early stages of cortical organization. The secondary sulci develop later and are essentially the branches or ramifications that emerge from the primary sulci. Here on the right side of the screen, you can observe the fetal brain development across various gestational ages. Up to 22 weeks, there is only minimal sulcal development. However, as the gestation age advances, you can clearly appreciate the dramatic progression of cortical maturation the brain is undergoing during this period. In this image, the fissure we are assessing is the parieto-occipital fissure. A key principle to remember when evaluating any sulcus on ultrasound is that the sulcal development is best visualized when the imaging plane is perpendicular to the expected course of the sulcus. This is what is demonstrated here. The red line indicates the plane that runs perpendicular to the parieto-occipital fissure. By acquiring the images along this orientation, the fissure becomes much more clearly defined, allowing for better assessment of its presence and development. In this slide, we are going to see the five major sulci and fissure that are essential to assess the cortical maturation in fetus. The first one is the lateral sulcus, also known as Sylvian fissure. This is the earliest sulci to appear, and it will serve as an important anatomical landmark. The second one is the parieto-occipital fissure. This separates the parietal and the occipital lobes. The third one is the calcarine sulcus, located in the occipital lobe and is closely associated with the primary visual cortex. The fourth one is the cingulate sulcus, which lies superior to the corpus callosum and is best appreciated on the midline sagittal views. And also, coronal views are used for the assessment of them. Finally, the convexity sulci or the superficial sulci is seen on the outer convex surface of the brain. It is important to remember that these sulci appear later in gestation and they reflect more advanced cortical folding or gyral maturation. In this slide, we can see the timing of sulcal development. We can see that there is consistent delay between the anatomical appearance of the sulci and their visualization on imaging. And there is also difference between the appearance in ultrasound and in MRI. For instance, the parieto-occipital fissure and the calcarine sulci anatomically appears around 16 weeks, but are typically seen first in ultrasound around 18.5 weeks and consistently between 20 to 22 weeks. The cingulate sulcus, which appears anatomically by 18 weeks, becomes reliably visible only after 23 to 24 weeks on ultrasound. The convexity sulci, which are superficial and reflect more advanced cortical maturation, appear much later and often after 25 weeks of gestation. The second table summarizes the minimum gestation age at which these sulci can be detected. The most important takeaway from the slide is the always seen column under ultrasound. This column indicates the gestation age by which each sulcus should consistently be seen in ultrasound in a normally developing fetus. So if a particular sulcus is not visualized beyond this gestation age, it should raise a concern for delayed sulcal development, and these fetuses should be followed up serially. Therefore, these thresholds will serve as a critical diagnostic benchmark during the fetal neurosonogram evaluation. There are two methods of assessment of the sulci. One is the subjective method, which relies on the visual impression of the sulcal appearance based on the pattern recognition. This includes assessing the presence, shape, depth, orientation of any particular sulci. The second is the objective method, which involves quantitative measurement like sulcal depth. Let us first see the subjective method of assessment. Now let us look at the lateral sulcus, also known as Sylvian fissure, which is one of the earliest and most important sulci. Look at the image in the left upper corner. Here we can see that the lateral sulcus typically appears in a triangular shape with postero-superior apex and antero-inferior base, as illustrated by a dotted lines. It is because of this triangular configuration, its ultrasound appearance changes depending upon the level of the axial scan. The image in the upper right corner demonstrates how the visualization of Sylvian fissure varies at different scanning planes, highlighting the importance of using a consistent anatomical landmark for accurate assessment. As shown in the first diagram, the level for the assessment of SFO is below or inferior to the BPD plane. In this plane, you see the fornix, thalamus and the posterior complex along with the SFO. In earlier publications, Dr. Giba has described about the sequential changes in the appearance of the lateral sulcus across the gestation age. In the image, note that the base of the lateral sulcus is first divided into two halves, and then the posterior half is further subdivided. The reason behind this is that we focus on the posterior lip because it undergoes the most significant morphological change and it contributes more prominently to the closure of the lateral sulcus. Now let us see the appearance of the lateral sulcus according to the gestation age. Up to 17 weeks of gestation, the fetal brain surface is almost completely smooth. Around 18 weeks, the lateral sulcus begins to emerge as a small mound, and by 19 to 20 weeks, it progresses into a plateau-like structure with obtuse angle between the insular cortex and the posterior lip of the lateral sulcus. At approximately 24 weeks, this angle becomes 90 degrees, representing a key morphological milestone. By 26 weeks, the angle becomes acute, indicating further infolding and deepening of the lateral sulcus. At 28 weeks, the posterior lip of the sulcus reaches halfway into the posterior half of the lateral sulcus. By 30 weeks, it extends to cover approximately 3/4 of the posterior half. And finally, at 32 weeks, the posterior lip completely overrides the posterior half. The same author had later developed a grading system for the same, which is a semi-quantitative score to assess the degree of opercularization. Now this slide is regarding the Pistorius grading of Sylvian fissure. He has developed a standardized and reproducible method to assess. According to this grading, grade 1 is shallow indentation, grade 2 is obtuse angle or 90-degree angle, grade 3 is acute angle or less than 50% of opercularization, Grade 4 is more than 50% of operculation, and grade 5 is complete closure. Now you might be wondering, how do we calculate the percentage of operculation? First, measure the length of the base of the Sylvian fissure. This is labeled as Y in the diagram. And then next, measure the gap between the two lips of the fissure. This is labeled as X. Now the formula to calculate the percentage of closure of Sylvian fissure is Y minus X divided by Y into 100. In this article, the author had visualized lateral sulcus in the axial transthalamic plane. When assessing the Sylvian fissure, it is important that we visualize both sides because the asymmetry can even be present unilaterally. Let's move on to the assessment of the parieto-occipital fissure. This fissure is better seen in the axial plane compared to the conventional transventricular plane. The ultrasound images demonstrate the progressive morphological changes of POF with the gestation age. This is the assessment of calcarine sulcus, which is located in the occipital lobe. The plane used for the assessment of this is the coronal transcerebellar plane. The ultrasound image represents the sequential developmental changes of calcarine sulcus across the gestational age. Here you can see that the same cortical grading that is used for calcarine sulcus is what is used for POF, cingulate, superior temporal and central sulci. The box plot at the bottom shows the expected distribution of grades by gestation age in normal fetuses. Cingulate sulcus is the sulcus that is situated above the corpus callosum. It is assessed in coronal transcaudate or transthalamic plane. The method of grading is similar to that what we have discussed already. Now the next sulcus that we are going to see is the cortical surface sulcus. The cortical sulci are located on the lateral surface of the brain, so we can assess them only on one side at a time. This makes it essential to evaluate both sides to complete the assessment. Another important distinction from deeper sulci is that the cortical surface sulci develop later in the gestation. So their appearance and progression reflects advanced stages of brain maturation. The best plane to assess this is the axial transthalamic plane. The grading of cortical sulci is completely different from what we have seen in deeper sulci such as calcarine, cingulate and POF. Once multiple sulci starts appearing, then its depth must be compared with the width, and grading is assigned based on this relationship. As the gestation age advances, the multiple cortical sulci undergoes branching, and this indicates increasing complexity of cortical maturation as the gestation age increases. In the ultrasound image, you can see that the orange color arrow points towards superior temporal sulcus. This generally appears at around 28 weeks. And in the next slide, you can see the green color arrow. This points towards inferior temporal sulcus, which appears close to superior temporal sulcus, but it appears later, and we can almost see it around in 30 to 32 weeks. You can see the inferior temporal sulcus in majority of the cases. Now let's move on to the assessment of a peculiar sulcus, that is olfactory sulcus. The olfactory sulcus is unique because it is not only used to assess the cortical maturation, but it also plays an important role in evaluating a specific genetic condition called CHARGE syndrome. Now let's see a small recap about CHARGE syndrome. It's an acronym that stands for coloboma, heart defects, atresia of Guiana, growth retardation, genital anomalies, and ear abnormalities. It has autosomal dominant inheritance, and most cases are due to CHD7 gene mutation, and among that, majority of them are de novo mutations. So having understood about this, whenever you come across conotruncal cardiac abnormalities, it is better that you evaluate this olfactory sulcus in the follow-up period. Why it is assessed during follow-up period? Because the olfactory sulcus begins to develop only after 26 weeks of gestation. Therefore, in follow-up cases, this assessment should be included after 26 weeks to avoid false impression of non-visualization in the earlier gestation. Will the sulcal development on both sides be concurrent, or can there be any asymmetry? What is asymmetric sulcal maturation? It is defined as the difference of at least one grade of development between any sulci in both hemispheres. It occurs commonly in cases with unilateral ventriculomegaly. Studies have shown that such asymmetry is common among the deeper central sulci like calcarine, cingulate, and parieto-occipital fissure. Now, what is the pathophysiology behind this asymmetric sulcal development? It may be because of consequence of deformation caused by the ventricular dilatation, or it may reflect changes in the brain architecture arising from the alteration in cerebral neuronal migration or proliferation. The reason why this does not occur consistently in all cases with unilateral ventriculomegaly is also not very well known. However, the studies have shown that this asymmetry tends to resolve before the delivery. Now let's move on to the objective method. Is it mandatory that you have to do objective method of assessment of this sulci in all cases? No. No, it is not mandatory to assess in all cases. But it may be important in cases like unilateral ventriculomegaly or any other cases where you suspect cortical maturation defects. Only if you start practicing the measurement in normal fetuses, you will be able to make it out better when there is any abnormality. The plane used for the objective measurement of Sylvian fissure is the standard BPD axial plane of fetal head. In this view, we can clearly identify the CSP, cavum septum pellucidum, and the posterior horns of lateral ventricles and choroid plexus. It is important to make sure that the midline is equidistant from both sides of the calvarium so that the plane is not oblique. Otherwise, our measurements will be inaccurate. Now let's see the first step in measuring the insular depth. From the midline, we draw a perpendicular line towards the upper border of the insular cortex, ending at the point of maximum prominence of insula. This can be seen as the solid line in the figure. Now what we have measured is the insular depth, and the line is called insular line. Now the next step is to measure the Sylvian fissure depth. For this, you have to measure from the insular cortex to the inner table of the parietal bone, making sure that it is in continuation with the insular line, again in perpendicular to the midline. From the graph, we can make out that the insular depth and the Sylvian fissure depth increases in proportion with the gestation age. Now, let us discuss about the coronal view assessment of Sylvian fissure as described by Dr. Poe. This method uses transvaginal 3D ultrasound with high frequency transducer, typically 5 to 9 or 6 to 12 MHz. As a first step, you have to visualize the sagittal plane of the fetal brain. Next, you should move the probe towards the anterior frontanel. The third step is, with appropriate pressure, rotate the transducer to obtain the anterior coronal view showing both Sylvian fissure. Here, why are you applying pressure? Pressure means you have to stabilize the head such that the fetal head does not move when the transducer is rotated. Remember that the degree of rotation from sagittal plane should be 90° to make it exact coronal. When the acquisition is started, make sure that the imaging of the entire fetal brain is acquired. In this four-quadrant display, the coronal plane appears in view A. This is the primary plane of image acquisition. In view B, you will see the sagittal section, while in the third quadrant, view C will display the axial plane. This arrangement allows us to simultaneously assess the coronal acquisition view along with its corresponding sagittal and axial orientation. Before proceeding to the measurement, it is essential to make certain adjustments to ensure that fetal brain is properly oriented. This step guarantees that the sides of the fetal brain are correctly aligned. The first step is to go to the view B, where we get to see the sagittal section of the brain, and the frontal lobe should be on the left side of the screen. A horizontal line should be drawn from the genu of the corpus callosum to the end of the splenium of the corpus callosum. Now move on to the view C, where you get to see the axial section of the fetal brain. Now rotate the image in such a way that the frontal lobe is positioned downwards and the midline of the fetal brain is aligned exactly with the vertical reference line. Once these adjustments are completed, in view A, the left side of the displayed image corresponds to the right hemisphere, while the right side of the displayed image corresponds to the left hemisphere. As a final step, move the 3D reference point in view B to the anterior portion of the tela choroidae. Finally, we are moving on to the measurement step. In this, the first step would be to draw a horizontal reference line which need not pass through any specific brain structure. The second line is drawn along the upper border of the right Sylvian fissure and the third line along the upper border of the left Sylvian fissure. The angle between each Sylvian fissure line and the horizontal reference line are then measured. The angle above the horizontal line are recorded as positive and those below are recorded as negative. The graph given here shows the nomogram for Sylvian fissure angle. An important observation is that the SFA crosses the reference line from positive to negative at around 25 weeks of gestation or when the head circumference reaches 220 mm approximately. At this time, the Sylvian fissure angle will shift to a more negative value. This picture shows the sequential development of the Sylvian fissure from 18 to 13 weeks of gestation. Another important advantage of this coronal view is that it allows simultaneous visualization of both Sylvian fissure. This helps in identifying both the sides as well as we can have a direct comparison between the both sides. As we already know, the optimal plane to visualize the POF is obtained by angling slightly above the standard transventricular plane. Once this plane is acquired, the POF depth is measured by drawing straight perpendicular line from the midline to the deepest point, that is the apex of the fissure. The depth of the calcareous sulcus can also be done in the similar way, and the nomograms are given in the chart and the table. Finally, this slide serves as a concise summary of both technique of grading and measurement of depth of various sulci and fissures. Insular depth, Sylvian fissure depth, depth of POF, calcareous sulcus and cingulate sulcus, everything is shown together, and even the grading along with the picture is given, so that I recommend you to have a screenshot of the slide and keep it readily available in your workspace so that it can be a really quick one and an invaluable reference during your practice, especially when you're going to assess the cortical maturation and development. Now it's time for self-assessment. In the first method, ultrasound images will be given from different patients and you have to assess the grade and thereby guess approximate gestation age for each image of same sulcus. In the second method, ultrasound images of various sulci will be given from the same patient. You have to assess the grade and guess the approximate gestation age of the fetus. I hope you all enjoyed the self-assessment session. I'm sure by now you all would feel confident and familiar with not only the grading of sulci and gyri, but also regarding the assessment or approximate assessment of gestation age based on this grading. Thank you so much for watching. If you like this video, please subscribe and share to your friends.